Hello, everyone. This is Carolyn Moore, and I'm the Secretariat Director of the Global Handwashing Partnership. I'm excited to welcome you all to today's webinar on mobile messaging to facilitate handwashing with soap behavior change. Welcome and thank you very much for joining us. If you're just getting logged in, a couple of quick housekeeping notes. We are using the Adobe Connect platform for our webinar today. If you're joining as a participant, we won't be able to hear you. Your microphone is on mute, but if you use the chat box in the lower corner of the screen to ask any questions or comments throughout the presentation, we'll be sure to address those in the discussion section. And please introduce yourselves right now, as I can see many of you are doing. So we'll get started with the presentation in just a moment. We'll have our presentation from Dr. George for about 20 to 25 minutes, and then we'll have plenty of time for discussion after that, and then we'll close out with a few quick announcements. So please feel free to type your questions for Dr. George. As she's presenting, we'll pick those up in the discussion section as well, and we really welcome your reactions, questions, comments, etc. So I'm excited to introduce our topic for today, which I think is going to give us a really interesting look at the value added with a mobile messaging component to an already robust behavior change program, looking at the example of the Chobi 7 program in Bangladesh. Dr. Christine Marie George is an associate professor at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health. She is an environmental epidemiologist and environmental engineer whose career focuses on identifying transmission routes for environmental exposures and the development of WASH interventions to intervene upon identified transmission routes. So welcome, Dr. George. We're excited to have you here. Over to you.
Thank you, Carol, for the opportunity to be able to present today. So today I will be presenting on our research evaluating the use of WASH mobile health messages as a behavior change technique to facilitate increased hand washing with soap and water treatment practices in Bangladesh. Our project is a collaboration between Johns Hopkins as well as the International Center for Diarrheal Disease Research, Bangladesh, iccdr, and the Bangladesh Ministry of Health and Family Welfare. And so I'd like to start the presentation by acknowledging our large study team that has all contributed to the implementation of the Chobi 7 project since 2013. So for today's presentation, I'll start by providing some background on our study rationale, and I'll describe the Cholera-Hospital-Based-Intervention for 7 days, Chobi 7. I'll go into the development of our mobile health program, as well as the randomized control trial that we conducted to evaluate the effectiveness of this approach, and then we'll describe our current and upcoming work. So the rationale behind our study is that when a cholera patient presents at the hospital, their family members are at 100 times higher risk than the general population of developing a subsequent cholera infection. And this is likely because they're sharing the same contaminated environmental sources, such as drinking water, as well as through person-to-person transmission in the home through, for example, poor hygiene practices. And it's really the first week after the case presents at the hospital that the family members are at highest risk of developing a subsequent cholera infection. However, despite this high risk, there's been little work done to develop interventions to target this very high-risk population. And so this led to the development of the Cholera Hospital-Based Intervention for 7 days, which the acronym is Chobi 7. Chobi means picture in Bangla for the pictorial modules that are delivered as part of this intervention. The Chobi 7 intervention is delivered bedside to the cholera patient and their household members by a health promoter who explains how cholera is transmitted and promotes hand washing with soap and water treatment to prevent cholera. The communication module that's delivered in the health facilities is then reinforced through home visits during the 1-week high-risk period. And as part of the intervention, we provide enabling hardware, which includes a hand washing station. And so this was developed by the iccdr WASH group. It includes items that are commonly found in the home in Bangladesh. So a bucket with a tap on it, a stool, and a basin as well as promoting the use of soapy water, which is water and detergent powder, and serves as a low-cost alternative to bar soap, which is about a 20th the cost of bar soap. As part of the intervention, we also provide a water vessel with lid for safe water storage and chlorine tablets. This study was conducted at iccdr Dhaka Hospital, which is the capital of Dhaka, it's the capital city of Bangladesh. And to give you a sense of the patient volume in this hospital, in a given year, there's more than 100,000 diarrhea patients that are presenting, with about 11% being cholera, culture-confirmed cholera. And so we conducted a randomized control trial of the CHOBI-7 in comparison to the standard message given in Bangladesh on the use of oral rehydration solution at discharge. And we found that this intervention led to a 47% reduction in overall cholera infections in household members of cholera patients. So it showed that this intervention was effective at reducing cholera during this 1-week high-risk period. So the findings from this study were disseminated to the Bangladesh Ministry of Health and Family Welfare. And they were really interested in taking this intervention to scale across Bangladesh and health facilities. And they asked us to build additional evidence on scalable approaches for delivering this intervention. And so based on the recommendations, we submitted a grant to USAID to do a scaling plan for the CHOBI-7 intervention and to conduct a second randomized control trial. And so this led to our current work, which I'll present on today. And so our current work focuses on investigating the use of mobile health to serve as nudges to facilitate WASH behavior change to reinforce the messages delivered in the health facility. So the mobile health is one component of a larger intervention, and the idea is that instead of doing home visits as we did in our previous study, we're very interested in seeing if we can use mobile health as nudges to reinforce messaging without requiring home visits. And our objective was to increase hand washing with soap and water treatment during the 1-week high-risk period, and also to promote sustained behavior change over time. Another important aspect of the current scaling approaches that we're working on is that the Ministry of Health and Family Welfare asks us to broaden the scope from just focusing on cholera patients to broadening the scope of the intervention to include diarrhea patients of all etiology. And this is supported by the scientific literature that shows other infections are also at a very high risk. Family members are at a high risk during the period after the case presents at the hospital. For example, Shigella or enterotoxigenic E. coli. And so this form of intervention has the potential to reduce many different enteric pathogens that are transmitted within the household. And so the objectives of the current study that I'll present today were to develop the CHOBI-7 mobile health program, and then to evaluate the effectiveness of this program. And so the key behaviors that are promoted through the mobile health messages are hand washing with soap, and again promoting the use of soapy water, which is water and detergent powder. We're promoting a chlorination of drinking water during the 1-week high-risk period after the cholera patient or the diarrhea patient presents at the hospital, as well as safe water storage through using a water vessel with lid. And so to develop the CHOBI-7 mobile health module, we conducted 8 months of formative research. And this included semi-structured interviews with government stakeholders as well as diarrhea patient households. We had focus group discussions, and we also conducted a pilot in 52 households. So now I'll go into some of the findings from our formative research and describe how this informed our intervention development. And so government stakeholders strongly recommended the use of mobile health messages to deliver public health information. They describe how they were currently using a mobile platform where they were sending out messages during disease outbreaks and also during health awareness days, such as community clinic days. The high phone coverage in Bangladesh was really seen as a strength in terms of using it as a way to, mobile health as a way to deliver information. And so in this quote here, this government stakeholder says that 90% of our people are connected with mobile phones. And this is consistent with our own mobile health surveys that we've done in slum areas in Dhaka, where we found that over 90% of households reported mobile phone ownership. And so to be the sender of our mobile health messages, we selected a physician from iccdr Dhaka Hospital. And this was based on our formative research findings. A physician was seen as a person that provided credible information, and both diarrhea patients and diarrhea patients and their household members, as well as government stakeholders, recommended that iccdr Hospital, given that it was the lead diarrhea treatment center in Dhaka, would be the ideal sender of these messages. And so this photo here is of an actual physician that works at Dhaka iccdr Hospital, and we changed her name to be a character for our intervention to be Dr. Chobi, which is the name of our intervention program. And so now I'll go through some example messages. And I should say that we have many more messages than this, and we target both S2 and S1 drivers of behavior change. But today I'll focus more on our health-based messages. But in terms of addressing questions at the end, I would be happy to discuss some of our other messages in detail. So in this message, Dr. Chobi is saying that she is calling from the Cholera-Hospital. And so iccdr Dhaka Hospital is also referred to as the Cholera Hospital. And she asks the diarrhea patient that received the Chobi 7 module in the hospital if they're using the soapy water that we provided. And then is explaining to them how they can make more soapy water. She also explains in her messages when patients and their household members should be washing their hands with soap, and then encourages them to share the messages with others. And so through our formative research, we really learned a lot about the importance of message sharing. And so sometimes in the household, or very often, there'll only be one mobile phone, and it may be owned by the male household member. And so we found that it was important to emphasize in all messages that please share the words to all family members. And so we also send text messages out to households, and I show an example here. And this one is emphasizing the use of chlorinated water and hand washing with soap to create a shield of good health, and encouraging people, if they're not performing that behavior now, to start right away, and again to share the messages. And so we'll talk more about the S1 and S2 drivers during the discussion. And so in addition to Dr. Chobi, we had another character which was a peer role model, and this was Aklima. And Aklima was a diarrhea patient that presented at the Cholera Hospital. And so in our voice messages, Dr. Chobi has discussions with Aklima. And so here, for example, she's asking Aklima how she treats her water with chlorine. And then Aklima explains how. Dr. Chobi congratulates her for getting the answer right, and encourages both her and the people who are listening to tell them that they are now experts and they should share this information with others. We also included a male peer role model because we wanted to make sure we also included the male household members in the mobile health program. And so here we have an example where Dr. Chobi is talking to Aklima's husband and asks him how his family is doing. He explains how his children used to have frequent diarrhea, but since they've been adhering to the intervention, they're now healthy. And he talks about how he shared the messages that Dr. Chobi had sent with his family. And so the idea here is to help to build response efficacy. And so through our qualitative work, we did semi-structured interviews with those people who received the messages during our pilot, and we found a very positive response for both Dr. Chobe and Aklima. People said that they could feel Dr. Chobe's words from their heart, and for Aklima, people really identified with her as a patient that had gone to the hospital, saying that it was good that she was taking advice from Dr. Chobe. And one patient even said, "I am Aklima. It's me, not Aklima." So people really identified with her. We found a positive response for both the text messages and the voice messages that were sent. The text messages were seen as a great way to be able to share the content that was sent with others, and also a way for people to go back and look if they forgot the messages. And this was possible because in the context of where the study was conducted, which was slum areas of Dhaka, the household literacy rate was high. So over 90% of households had at least one person that could read. And so this really was a benefit in terms of being able to share messages within the households. And so for the voice messages, people really liked those because they were able to hear Dr. Chobe's voice and Aklima's husband. And so participants on that in the pilot recommended a combination of both these voice and text messages. The messages from Dr. Chobe were seen as an important way to spread awareness and improve health, with participants saying that if they adhere to these behaviors, that they would be free from all diseases. So based on the findings from the formative research, we developed our Chobe 7 mobile health program, which is delivered over a period of 12 months and sends voice and text messages every 2 weeks. We use the VMO platform to send these messages. And so I see the question there. So we send messages every 2 weeks to households. And so, as I mentioned before, the mobile health program is part of our larger Chobe 7 communication module. And so the initial part of the Chobe 7 module is delivered in a health facility. It includes the pictorial module that's delivered by a health promoter. And as part of the scalable version in the hospital, we mentioned who Dr. Chobe is, that Dr. Chobe will be contacting the diarrhea patient households over the next year, when the messages will be sent. And so we provide this information in the health facility before patients go home. We also provided the facilitating hardware, which included the hand washing station, soapy water, as well as a sealed water vessel, and cue cards to serve as cues to action to perform the promoted behaviors. And so here I show the design of the second randomized control trial that we conducted of the scalable approaches to implement the Chobe 7 intervention. And so this study was conducted also in Dhaka, Bangladesh, and our focus was in slum areas. We included Dhaka iccdr hospital, as well as Mugda General Hospital, which is a public hospital that serves 80,000 patients each year. And so diarrhea patients were randomized to be in one of these 3 arms based on the day that they came to the hospital and the ward that they were in. We had a standard message arm that received information on oral rehydration solution use at discharge. And this is the standard recommendation that was given in Bangladesh. And the second arm was the delivery of the Chobe 7 module in the health facility, and then reinforcement through the mobile health messages. And this was considered the most scalable approach for implementation. And then we also looked at this same approach plus 2 home visits. The 2 home visits, unfortunately, are blocked here in this photo. And so again, we have the standard recommendation arm. We have the Chobe 7 delivered in the health facility plus mobile health messages, and then the same intervention plus 2 home visits. And so we followed diarrhea patient households over a 1-year period at these 6 time points. To assess our behavioral outcomes, we conducted 5-hour structured observation of hand washing practices at food and stool related events. We also conducted unannounced spot checks where we collected a sample of the household's stored drinking water and tested this for E. coli. Our trial is currently ongoing, and so for today I will present on our findings from day 7, which represents the 1-week high-risk period for subsequent diarrheal diseases within the household, as well as our 9-month follow-up. We plan to complete the trial in April. And so now I'll go on to our findings. At our day 7 follow-up, we observed significantly higher hand washing with soap in both our CHOBI 7 health facility plus mobile messages arm, and also the arm that had the same intervention plus 2 home visits. When we looked at water quality during the 7-day high-risk period, we saw that relative to E. coli, using the WHO cutoff of less than 1 colony forming unit, only 8% of households met this guideline in the standard recommendation arm, and this was 51%. And the CHOBI 7 arm that received the mobile health in the hospital, received the CHOBI 7 module in the hospital and the mobile health. And then this increased slightly for the households that also received the home visits. So now going on to our 9-month follow-up, which was more of a measure of sustained wash behavior within these households. And we also observed significantly higher hand washing with soap by structured observation in both of our intervention arms compared to our standard message arm. And then for our water quality at our 9-month follow-up, we did not see a significant difference relative to the WHO cutoff of less than 1 colony forming unit per 100 ml of E. coli. However, when we looked at the very high risk category of greater than 1,000 colony forming units per 100 ml, we observed a significant reduction in those households in the intervention arms in terms of a reduction in those that were in the high-risk category. It was 28% in the standard message arm, and it's decreased to 13% and 17% in the 2 CHOBI 7 arms. So in summary, we found that the CHOBI 7 mobile health program resulted in significantly higher hand washing with soap and improved water quality, both during the 1-week high-risk period as well as behavior that was sustained at our 9-month follow-up. In addition, and a really important finding was that health facility delivery of the intervention alone plus mobile health without home visits was sufficient to lead to increased wash behaviors that were sustained at the 9-month follow-up. So I should emphasize again, in that middle arm, we just had health facility delivery of CHOBI 7 plus mobile health messages. There were no additional home visits, and we still observed significantly improved water quality and hand washing with soap at the 9-month follow-up. And so these findings demonstrate that mobile health presents a promising approach to facilitate wash behavior change in this setting. And so I wanted to briefly mention our current and upcoming work. Last year, we received a WashPals grant to expand the scope of the CHOBI 7 intervention to include additional behaviors. And these include child mouthing behaviors, so discouraging children from putting visibly dirty objects into their mouth, encouraging caregivers to watch their children when they're playing, and also encouraging caregivers to clean toys that children play with frequently. We're also currently working on formative research around a mobile health food hygiene module to encourage us storing food with a cover as well as reheating of food, and then a third module on child feces disposal practices. And so we're 7 months into our formative research, and we're planning to roll out the randomized control trial in the upcoming months of these new CHOBI 7 mobile health modules. And so I'd like to conclude the presentation by acknowledging our team at iccdr. And I would like to have a special acknowledgement to Dr. Minarul Alam, who is our iccdr Principal Investigator, as well as Fatima Zora, who designed a lot of the CHOBI-7 communication materials, as well as our collaborators at the Bangladesh Ministry of Health and Family Welfare. And so now I would like to open.
Thanks very much, Dr. George. This is Carolyn again. And I wanted to introduce Na Noyan of USAID, who will be moderating our discussion today. Na is the Senior Water, Sanitation, and Hygiene and Social Behavior Change Advisor in the Office of Maternal Child Health and Nutrition. She'll be fielding all of the great questions that you're asking in the chat box. And so we do see those coming in. Please keep those going. And I'll turn it over to you, Na.
Hi, just a sound check. Everyone can hear me?
You sound good.
Great. Well, thank you, Dr. George, for the great presentation. I've actually known about the CHOBI-7 work for a while through our Wash Health grant, but then also hearing Dr. George present. But I tell you, every time I hear this presentation, I learn something new, and I think that for me, it's a great example of sort of two aspects. One is that actually there is evidence that low-cost interventions such as mHealth is successful at changing behavior. But I think it's also, the CHOBI-17 is also a great example of what we call continuous learning and adaptation in USAID, is that the program started as a pilot. It showed the effectiveness between cholera households with the CHOBI-17 versus households that didn't have the intervention. Then you scaled it up. You iterated and modified the intervention, and now you're looking to see the impact of mHealth. And now the next phase is looking at new behaviors and how can we use this approach in looking at other hygiene behaviors. So I think it's really a really fantastic program, and I'm looking forward to seeing the results both at the 12-month and as well as through the Wash Health Small Grant. So with that, I would like to turn it over to some questions. We have some that came in when people registered for the webinar, and the first question I thought was interesting is that, Dr. George, are there other mHealth programs that have been applied in WASH?
So I think this is a very new area, and I actually saw in the chat bar, and I had heard of how Lifebuoy is working now on mobile health messages around hand washing with soap. And so that's the only other program that I know of that's utilizing mobile health to facilitate wash behavior change.
Okay, great. There was a question from, keep going. Yeah, go ahead.
I should mention that study is being conducted in
Okay, great. There was a question from Unilever asking about the 47% reduction. Was that credited to the mobile intervention, or the hand washing station was also an influencing asset?
So in the original, the 47% reduction in cholera and then initial CHOBI-7 study?
Yes, I think so, yep. Mm-hmm.
So at that time, we were not using mobile health. This was the initial intervention that had the home visits, hospital delivery and home visits. But however, in the current study, we're collecting stool samples, so we'll be able to look at the impact of the intervention in reducing enteric infections. So we'll be able to look at cholera, enterotoxigenic E. coli, and other pathogens.
Great. Okay, and then a question from Julia. Could you please clarify what the S1 and S2 messaging are?
Yes, I would be happy to. So in terms of the S1, they're more, so the S2 is more health-based type messages. The S1 drivers, there are several key principles. One of them is managing physical availability, so ensuring that products are available when people need them. There's context change, so examples of that are sending out messages during the hot season or after a flood event or during the rainy season. And so we do that as part of our current mobile health messages. Another S1 driver is piggybacking on existing behaviors. So an example of that is that we send out people a message during meal times when food is usually being prepared. and reminding household members, did you wash your hands before you prepared your food today? So messages like that. And also one that we apply is the descriptive and localized norms. And so an example of that is that we use our surveillance data to be able to tell households what percentage of people are reporting washing their hands with soap at a key time, for example, or are reporting for our upcoming work, safe child feces disposal, to try to increase the descriptive norms around those behaviors.
Great. There was another question about what is the optimal timing for messaging? How do you account for household rather than individual ownership of phones, including for women?
So that's great. So first I'll talk about the timing. And so the timing was something that's really important because if you only have one phone in the household, for example, you want to try to target a time when most people in the household will be present. And so through our formative work, we found that the evenings were the time when you had the most people present. And right before dinner time is when we are sending out our messages. And we're finding that that's when we're able to capture the most people in the household. In terms of targeting people who may not own the phone in the household, in our Bangladesh context, the majority of the primary phone owners in the household were male. And so this was one of the reasons why we really encourage message sharing. So the mobile messages that were sent, we always state, please share these with other people in your household. And excitingly, when we look at our data, we see that over 85% of adults in the household are reporting that they've received a message from us in the past 2 weeks. So it's been very high, and we think it's because of the tailoring of the intervention that we did based on the formative research findings.
Great. There was an interesting comment related to that question in that in Bangladesh, someone says that in Bangladesh it has 51% of households own a device, but the subscription is 87% of households, which is evidence that people are sharing phones or having multiple SIM cards. Another question, did the low literacy rates affect low literacy rates amongst the beneficiaries? How did that affect them?
So that's a
and
great
what
question
platform did you
also.
use to send the messages?
So that's a great question also. And so we were concerned about that, and that was the reason why we began wanting to send both voice and text messages. And so we did have some cases where no one in the household was able to read the messages that we sent, the text. But we also sent a combination of voice messages, so they were able to listen to those.
Great. There is a question about the cost of the program. Someone is saying, is it possible to know how much per person did it cost? For my Africa experience, mobile phones, mobile and especially voice is very expensive. And at the moment, when you go to rural networks, becomes an issue. And of course, when you say mobile, it's with mail. So basically, the gist is, how much did it cost per person?
So that's a great question. And so to send messages every 2 weeks to a household to one phone for a year was $2 US. And this really probably varies by country. In Bangladesh, the cost is not very high. To send out, for example, a text message, I believe is about 4 cents. And then it's 2.5 cents per minute for calls. And so the cost is much lower than it is in other settings. So I think this is a really big benefit to utilizing mobile health in this setting.
So there was one question related to that came in from participants who registered for the webinar, and that was, how do we apply this approach in countries where technology is not so prevalent?
So that's a great question, and I think an area where we need additional research. This is WASH, and mHealth is a very new area to utilize mHealth to deliver WASH messaging. And so I think that additional research needs to be done in settings where phone coverage isn't as high as it is in Bangladesh.
Okay, great. A question came in. This is a great intervention. It's really innovative. Did you engage with multiple mobile service providers or just one?
So for this study, we used the VMO platform to send out the messages. And people who have different mobile providers can all receive the messages that we send. And so VMO doesn't just focus on Bangladesh. They have sites they provide the service across the world, and they work through local providers to send their messages.
In fact, I think in Haiti, somebody's commented that I think they also use the same platform, the same company. And his comment, Bram's comment, is that in Haiti, they found that a combination of text, voice messages work best, and that messages should differ. So the text messages help people remember to use chlorine, and then they use the voice messages for dialogues.
Yes, hi, Bram. And so that's the same approach that we use also. Where, as I mentioned during the presentation, the text messages are more serving as reminders in case people forget the behaviors, and also for them to share the messages that were sent with others, while the voice messages allow them to hear Dr. Chobi's voice, to hear Aklima and Aklima's husband. And so we've also found that a combination of these different types of messages is really valuable.
So to build on that, what do you think, Dr. George, could you reflect a bit on what was the added value of the messages and what wasn't? And maybe also, what was your hypothesis about why the extra household visits didn't make a difference?
So the additional household visits, there were 2 of them during the 1-week high-risk period, while our mobile health messages were sent out every 2 weeks over a year-long period. And so I think that through the mobile health messages that were sent out, they were able to serve as nudges that were facilitating behavior change over time, not just during that 1-week high-risk period.
Interesting. So it really kind of points to sort of the longevity of the messages and the contact. So I think we always think that interpersonal communications is sort of the gold standard, but we all know that it's extremely expensive and resource intensive. But then here, actually, I think what it's showing now is that actually, even if you have contact and it's not one-to-one, it can still be effective as long as you sort of maintain the longevity of the contact.
Yeah, I think the results are pointing towards that. Additional research is definitely needed to be able to evaluate that. And something else with the CHOBI-7 intervention is that we target people when someone in their house had severe illness. And so that's likely a time where people are more receptive to information on WASH. And so it's not the same as delivering this as a community-based intervention where we're sending it to households who may or may not have someone that has an illness in the home.
Right, really, it's very targeted messages. There's another question that came in. Do you know through your formative research whether these households also get messages from other sources?
Yes, so we explored that during our formative research. And the government sends out messages for health awareness days, such as Community Clinic Day. They have a Safe Motherhood Day in Bangladesh for which they send out messages. People also receive messages from different companies and ads, and so it was really important to make it clear in the messages we were sending out who we were. So we were sending messages from iccdr hospital, and so we made it clear that this was the cholera hospital. And so also in the hospital, when we delivered the intervention to households, we encouraged them to save our number in their phone so that when it came up, they knew who was calling.
Interesting. So it sounds to me like there's actually a lot of noise, what we call noise. So people are getting lots of different messages. And so I think that this program is clever in trying to understand how can we sort of cut through that noise and make our messages more salient when it's competing with many of the other messages. Okay, another question. Is there potential to scale this to people who are not at high risk, not in the high-risk period for cholera? Or do you think that the cholera case made people particularly receptive to changing their behavior?
So that's a great question. And so in the current study, we focused on diarrhea patients in general and not just those that had cholera. So for diarrhea patients in general, we're seeing these significant increases in these WASH behaviors. We recently received a grant from NIH, the National Institute of Health, to look at just sending messages out to people in different slum areas that may or may not have a severe illness in their home. And so I think the findings from that upcoming study will provide information to answer your question.
Great. When will that study start?
So we received the funding and we're starting our formative research this year. So the randomized control trial will probably start early next.
Great. Another question. Do you think your outcomes were impacted by messages from other sources?
They could have been. So we collect information on that. We have a mobile health survey that we give out monthly to households, and so we capture their exposure to messaging. So we'll be able to look at that.
Great. Anyone else? I would encourage other people. We've got a couple more minutes, so if you have questions, please put them in the chat box for Dr. George. What do you think? What do you think about mobile messaging in the result in the uptake of other habitual habits like hand washing, but other habits?
And so in terms of the Wash Pals work, we're looking at safe child feces disposal. We're looking at food hygiene and child mouthing. And so through our qualitative work, the households and messages we send seem to be resonating. But I think the randomized control trial will provide the information in terms of looking at if we see significant improvements in these behaviors.
And great. So do you think that there is an opportunity to create call centers as a way to scale?
So that's a great question. The Bangladesh government has a health call centers now where people can call in and speak to doctors about health-related questions. And so that's existing now in a popular service. People have to call in and they're charged a small fee for calling. But the government of Bangladesh has had success with that program.
Great. It makes me think of in the U.S. now that you don't actually have to go to your doctor. In fact, you can go online and sort of get consultation by a nurse online and being diagnosed for common things such as like a strep throat. So very interesting. Great to hear that they're also applying sort of the same cost-effective approaches in Bangladesh. So I'm going to I think that we have about 10 more minutes, and what I'd like to do now is I'd like to turn it over to Carolyn because there were also questions about, in general, the Global Hand Washing Partnership, and I think she is in the best position to answer those. So over to you, Carolyn.
Thanks very much, Na, and thanks, Dr. George. Just moving the slide. So we, in the opening to this presentation, also received some questions about the Global Hand Washing Partnership, what it is and what we do. So take a moment just to tell you about our work. The Global Hand Washing Partnership is a coalition of organizations working to promote hand washing with soap. And we have a steering committee of 9 organizations, and then we have just over 20 members. So we are a network of 30 organizations. We're open to new members and would be excited to have many of your organizations join us. Many of you already are members. And we focus on advocacy and knowledge management for hand washing behavior change. So we're trying to improve the enabling environment that's going to make programs like the one that Dr. George presented successful, looking at policy, investment, and strategy. And then we also focus on exchanging knowledge to improve hand washing behavior change programs from all sectors. So looking at how we can help people put research into practice, how we can help people learn from each other, and how we can sort of help spark new collaborations. I think many of you are probably familiar with Global Hand Washing Day, which is our largest day of the year that we spend celebrating the importance of hand washing with soap. But that's not all we do. We have lots of ongoing work, and we are very open to your questions and suggestions about how we can support advocacy and knowledge management for hand washing behavior change. So with this webinar, we're excited to launch a new initiative that we are calling Ask the GHP. Quite simply, we want to answer your questions about hand washing behavior change. So we're asking anybody who's working in hand washing. This could be from a research perspective, from an NGO or civil society, from the private sector, from a group that we haven't thought of yet. Any questions that you have about hand washing behavior change in communities, in schools, in health facilities, in workplaces, etc., please send them our way. We're asking people to send them using the hashtag #AskTheGHP on Twitter or Facebook, or you can email our general address, which is contact@globalhandwashing.org. This is the first of our Ask the GHP series webinars, so this is a question that we get a lot about how we can use mobile health and the fact that more and more people are consuming information via mobile devices to improve hand washing behavior change. And we do get lots of questions sort of in person and by email, and so this is an effort to put those out a little bit more to the community so that those questions can be answered in a public space. And as we get your questions, we'll be answering them through webinars, through social media videos, through pieces on our website, really sourcing throughout our network for experts who can give you a little bit of introduction or share their experience on issues that are relevant to your work in hand washing. I'll pause here, welcome any questions about the Global Hand Washing Partnership or about this initiative. Okay, well, I see a couple of questions being typed in, but I'll move on and we can come back to those. Next, I'd like to give my colleague Julia Rosenbaum an opportunity to tell you a little bit about a new grant opportunity through the WashPals project.
Thank you all. Just very briefly, but we want to spread the word. You may have noted that Christine Marie mentioned that she was managing another phase of this project through a WashPals small grant. And the WashPals project does have a mandate to issue small grants to test innovations in behavior change. And you can see before you the very rough parameters, but most essentially our keywords would be to test hygiene behavior change, and we define that quite comprehensively. So for this group, certainly anything to do with hand washing, also safe water, disposal of feces, disposal of child feces. And you'll see some more parameters outlined if you do log on to the call for expressions of interest. We anticipate issuing 6 grants, which would range from $50,000 to $150,000. So again, this does limit the scope of what you can do, but it's also a really great chance to do some kind of add-on to test to test and measure on an existing intervention. You'll see the link for more information on how to apply, how to write this expression of interest. I put a screenshot because it's a bit hidden on the site, but if you go down to the bottom of the page, you'll see a box where you link. Also, if you do Google Tetra Tech and WashPals, that will get you right to the page. Those are 2 ways to easily find the page. And we really do encourage, very widely, encourage people to consider putting in an expression of interest. And we look forward to some flowing from this webinar. Thanks. If there's any questions, general questions, I can also answer those, but you'll find a lot of information there on the site.
Thanks very much, Julia. We hope from this group we'll see some great hand washing proposals. We from the GHP would love to see this is an opportunity for some new innovations in hand washing. So we'll get ready to wrap up now. Thanks so much, Dr. George, for your great presentation and everyone for your questions. I'll just pause and allow any final comments or questions, any final reactions from Dr. George and from Na before we close. Dr. George, I'll start with you.
So I don't have any more additional comments, but I just want to thank everyone again and to tell people who are listening that we're really interested in collaborating on additional mobile health related programs. So if you're interested in collaborating with us at Johns Hopkins on this, please let us know.
Yeah, and I don't have any further comments, but just to say thank you, everyone, for all your really interesting questions. I think this is the questions that have come from this webinar are really thought-provoking, and I hope that if you're interested in the work, you will go and look up Dr. George's work and then forward on the recording to your colleagues and other hand-washing people interested in hand-washing. Thank you.
Excellent. Thanks very much, everyone. So this webinar recording will be posted on our resources hub with a summary, and you can also find lots more information about hand-washing behavior change, advocacy, hand-washing promotion on that page. So please visit us at www.globalhandwashing.org and do send this on to your colleagues. The link to this recording will be posted in a few days. Thanks very much. Bye.